There we are. So, good evening and welcome. I'm Jed Levine. I'm the President Emeritus at Caring Kind. And I am just so thrilled and delighted that we're doing this presentation today on vaccine updates and research. This is an issue for our caregivers and for people living with dementia. It's a very serious one, actually. And we know that people with Alzheimer's disease and related disorders develop COVID at double the rate of other individuals and have more serious consequences as a result. And in fact, just being older itself, 76%, I think, of the deaths from COVID were people 65 and over. So it really is a serious issue. Plus, you add in RSV, the flu, shingles, all of which older adults are at greater risk for, and again with more serious consequences. So I do want to, I'm really excited about tonight's presentation. Before I introduce Michelle Piskin, I just want to remind everybody, for anybody who's new to Caring Kind and is interested in or caring for somebody with Alzheimer's or any related disorder, Caring Kind is a great resource for information and especially support. All of our services are free of charge, and I encourage you to take a look at our website, which is www.caringkindnyc.org. I'll put that in the chat. And because I don't want to spend a lot of time you listening to me, I'm going to ask Michelle just to say a few words and then to introduce Olivia Frank from the NYU Vaccine Center. Let me also say that I am a proud member of the Community Advisory Board at the NYU Vaccine Center. It's really a very dynamic group of community partners and people from all over the city, and it's been a really wonderful experience. And I've learned a lot, and I wanted to bring that knowledge to our Alzheimer's and caregiving community. So, Michelle?
Well, welcome everybody for being here. I am also very excited to have this this seminar tonight. So timely as this time of year as we're all thinking about the next COVID vaccine that's new and out there, and should we have it? Should we have it? Did we just have COVID? When is the right time to get it after COVID? And then the flu vaccine and the other vaccines that Jed talked about. So very, very timely for this webinar. I'm Michelle Piskin. I'm the Vice President of Education and Training for Caring Kind. And I am so happy that you're all here to join us. Okay, go ahead. Olivia, would you like to?
Olivia?
Yeah.
I'll let you take it away.
Absolutely. Hi, everyone. Thank you so much for joining us. My name is Olivia Frank. I am the Community Engagement, Education, and Recruitment Coordinator for the NYU Langone Vaccine Center. We are very excited to be here. As Jed mentioned, we have a really strong relationship with Caring Kind. They have been Jed has been, and therefore Caring Kind has been one of the inaugural members of the Community Advisory Board since the COVID-19 pandemic began in 2020, and the Community Advisory Board was really created as a bidirectional communication method for updates on vaccines, both from the research standpoint to the community and from the community and their experiences back up to the researchers. So the fact that we are continuing in that tradition and continuing to bring the most up-to-date and accurate information to our communities is really something that we take great pride in and we take very seriously. So we are very excited to be here. I'm going to share my screen. I will be doing the slide deck for the day, and I will introduce a little bit about the Vaccine Center and then our speakers, and we will be off to the races. No. Oh, it was there for a second. Are we seeing my slides?
Yes.
Slides, or does it look more?
You're seeing the community updates in vaccine research and clinical care.
Yep.
You can try to put it in the presentation mode if you want.
Yeah, it looks like it's not showing only the slides. Hold on, let me double check what I've done here. Make sure it's in the best mode. Okay, there we go. Apologies, it's been 3 years, still don't know how to use Zoom.
There you go.
Okay. Now it's the full slides. It's not my Google Chrome. Amazing.
You got it.
Okay, so thank you so much for joining us again. Clinical and community updates on vaccine and clinical care is something we are very excited about. The NYU Langone Vaccine Center is actually housed within Langone's Division of Infectious Disease and Immunology, but we are very lucky because we have quite an interdisciplinary team. We work with pathologists, immunologists, vaccinologists, infectious disease experts. We have both team members in the adult and the pediatric realm. We have members that we work with who work more closely in the social sciences, along which Dr. Carmody is here with us tonight, who does work on vaccine hesitancy and community response and acceptance of vaccines. So we are one of 10 vaccine treatment evaluation units, which are called VTEUs. They are the federal sites that fund through the NIH, the largest and kind of most important federal funding and grant sources for the research into vaccines. We are very excited to have been members from the beginning of the COVID-19 Prevention Network, so the team that's really leading that vaccine and treatment research, as Dr. Backer will talk about in the future. And we have 5 sites. The picture on the bottom right shows we have 5 sites, 3 of which are in Manhattan, 1 in Brooklyn, and 1 out in Long Island. We do work, as I mentioned, everything from vaccine development to clinical trials and through to community education and vaccine acceptance and hesitancy, some of which is, part of the reason that we're here too, is that we really do take pride in our role in the education side of things as well. Our speakers today include Dr. Ellie Carmody. She is a principal investigator with us at the Vaccine Center, as well as an associate professor in the Department of Medicine at NYU Grossman. She's also the director of the Infectious Diseases Clinic at Bellevue Hospital. Dr. Lalitha Parameshwaran, who is the associate director of clinical research and a principal investigator with us at the Vaccine Center, and a clinical assistant professor of medicine in the Division of Infectious Disease and Immunology. And finally, Dr. Martin Backer, who is the clinical site lead and principal investigator for our Long Island site, as well as a clinical assistant professor of medicine in the Division of Infectious Diseases and Immunology. Dr. Backer is both an adult and a pediatric infectious disease specialist. So we are very happy to have 3 of our experts here with us today. A little bit of a roadmap of what we are going to look at. Very briefly, we are going to go over just like a vaccine 101 in the basics, make sure that our minds are right when we're talking about all of these updates, have a general sense of the science behind vaccines. We will do updates on various clinically significant and significant community illnesses and vaccine updates that you may be interested in. There will be short presentations followed by brief Q&A sessions. We encourage you to please put your questions in the chat. Jed has very kindly offered to moderate that, and we will be feeding questions to our experts as we go. And then lastly, we're going to do clinical trial updates, where we are with our ongoing and upcoming vaccine clinical trial work, and then a closing, how to stay involved and potentially get involved in vaccine center research. So with that, I am going to pass the torch first to Dr. Carmody, who will be going a little bit over vaccines and how they work.
Great. So thanks. Olivia, is the volume okay? Okay, great. So thank you so much. I get to do a little bit of the warm up and talk a little bit about how vaccines work very briefly, and then talk about a couple of vaccines that are not new but have updates and are also, I think, very important for individuals who are older adults. So, vaccine, I think we've all learned quite a bit about vaccines during the COVID pandemic. I think that this is meant probably review for most people, but vaccines are really they imitate infection to engage the body's defenses. And the active ingredient that's common to all vaccines is an antigen, and this is what produces that immune response. So really, an antigen is the name for any substance that causes the immune system to begin to produce antibodies and to produce an immunologic response. There are different types of antigens. Antigens can be like a weakened or killed bacteria or virus, like the measles. The measles vaccine is formed from a weakened measles virus. It could be bits of a bacterial or viral exterior surface. or genetic material. So examples of that would be for, I'll be talking about the pneumococcal vaccine, and there are little bits of the exterior surface on the pneumococcal vaccine which form the antigen that generates the antibodies to it. And then the genetic material, an example of that would be the COVID vaccine. So the mRNA vaccines are using genetic material as to create the antigen in order to generate an immunologic response. And bacterial toxins can also be antigens. So basically they're treated to make them non-toxic. And a common example of this would be a diphtheria toxin. Next slide. And I think this is just a very sort of powerful way of thinking about vaccines. So vaccines are like seatbelts, and we have different tools in our toolbox for prevention of sort of the consequences of infectious diseases. So we have, for example, hand washing and mask wearing, which can help us kind of, prevent sort of transmission of infectious diseases. And we can think of that as like defensive driving. We can think of vaccines like seatbelts. So basically they protect us. We need to have them in place before the incident occurs, before the transmission of infection occurs. And then medications, so these are medications, antibiotics, antivirals, they're deployed after the infection has occurred and after the problems occurred. But with all of these things, what we're trying to do is reduce the morbidity or the sickness and the death that occurs from infectious diseases. And vaccines are an important element of this. So this is my little part about updates in terms of community vaccinations for the 2023 season. And I'll be talking about two vaccines, the pneumococcal vaccine and the shingles vaccine. Go ahead. Okay, so pneumococcus and the pneumococcal vaccine is a very important, the pneumococcal vaccine is a very important vaccine for older adults. Pneumococcus, which is from Streptococcus pneumoniae, that's the name of the bacteria that causes pneumococcal disease. Pneumococcus is a considered sort of resident flora in the human respiratory tract. It can be found in the nasopharynx of healthy people, and it's spread by person to person by droplets in the air. In older adults and in young children, it can cause pneumonia, and it can cause meningitis and bloodstream infections that can be very serious and are called invasive pneumococcal disease. And it can be very, very serious. So basically, it does cause more than 150,000 hospitalizations in the US and more than 3,000 deaths every year. So you can see on the right what pneumococcus looks like under a microscope. Those little purple balls are the pneumococcus. And you can see underneath that an electron micrograph of the pneumococcus. And if you can see the two central areas of the darkness, those are the actual bacteria, and around that is their capsule. It's got this very thick polysaccharide capsule, and that's actually, we use little elements of that polysaccharide capsule, little sugars from that in order to make the antigen for the vaccine. All right, next slide. Great. So who's at risk for pneumococcal disease? Or really all adults 65 and older are at risk. And then there are other adults with chronic conditions, such as these listed here, which exacerbate the risk as well. So if you've had a solid organ transplant, if you've had cancer and you are taking medication and taking chemotherapy, if you're taking any medication that weakens the immune system, a lot of like medications for rheumatoid arthritis or Crohn's disease, etc., can weaken the immune system and can increase one's risk for pneumococcal disease. But really all adults 65 and older are at risk. Here on the left, you can see a chest x-ray of somebody with a pneumococcal pneumonia. Again, one of the common manifestations of pneumococcal disease. Pneumococcus can also exacerbate flu. So basically when someone has flu, they often then develop pneumococcal pneumonia following flu. This was actually one of the main causes of mortality in the 1918 flu epidemic, was actually pneumococcal pneumonia that had occurred after flu. Okay, next slide. So what are our vaccines for pneumococcus? They've been around for a long time. The polysaccharide vaccine, which is currently licensed, was actually licensed back in 1983. And that's, as I mentioned, composed of those long chains of sugar molecules that look like the surface of certain types of pneumococcal bacteria that help mount that immune response. It covers 23 types of pneumococcus, but it's a little less effective than sort of the more modern pneumococcal vaccines that are called conjugate vaccines. And conjugate vaccines, what they do is it joins like a carrier protein, something called a carrier protein, to sugar molecules from the polysaccharides, the polysaccharides from the surface of the bacteria. And the protein that's attached, that carrier protein, really helps the quality of the immune response compared to the unconjugated vaccine. And the numbers of these different vaccines, PCV 13, 15, 20, correspond to the number of sort of types of pneumococcus, or a number of sort of strains of pneumococcus that are currently covered by the vaccine. And so over the years, basically beginning in 2000 and 2007, and then now in 2021, we've actually gotten up to covering 20 types of pneumococcus with the conjugate vaccine. Next slide. So in 2022, the ACIP pneumococcal vaccine guidance changed because the new vaccine, PCV20, the new conjugate vaccine had come out. So at this point, there's really no one size fits all for pneumococcal vaccines. But I would say that it's very important to talk to your doctor about what's right for you based on your vaccine history. If you've never gotten any conjugate vaccines, it is recommended that you get the PCV20 one dose, or if you prefer, you could get the PCV15 followed by the polysaccharide vaccine, which is otherwise known as PPSV23, 1 year later. If you've had the previous polysaccharide vaccine, you should still get a conjugate vaccine. But if you've had both conjugate and polysaccharide vaccines, you don't need to get additional vaccines. So anyway, it's a little bit complicated. I think it's just important to talk to your doctor and make sure that you have the coverage for this vaccine if you're an older adult. And I just wanted to briefly touch on how do pneumococcal vaccines work. So really, they're very, very good in young kids and in older adults. So the graph on the right shows us how the implementation of pneumococcal vaccines really dramatically caused a decline in severe pneumococcal disease among children under 5. So the PCV7 was introduced in 2000, and then once we get to the introduction of PCV13, the incidence of invasive disease dropped even more. And for older adults, 3 in 4 adults, 65 and older, are protected against invasive pneumococcal disease by the PCV13. And we're hoping that number is going to be even higher with the PCV20. Next slide. So I'll very briefly just touch on shingles and the varicella zoster vaccine, the shingles vaccine. So this is another vaccine that's very important for older adults to have. Shingles is a reactivation of varicella zoster virus, which is really chickenpox. And nearly all adults born prior to 1980 have had chickenpox. What happens is the varicella zoster virus lies dormant in the body for somebody's lifetime. And when our immune systems when we get older, our immune systems can kind of weaken, they're less robust, and that virus can reactivate. So you're just having a reactivation of chickenpox with shingles. And shingles can cause very painful skin blisters, and it can lead to long-term neuropathic pain called postherpetic neuralgia. Fortunately, it's preventable with the shingles vaccine. Next slide. So really all adults older than 50 are recommended to receive 2 doses of the shingles vaccine, which is now the recombinant zoster vaccine. So that's come out in the past few years. That's the That's the licensed current vaccine on the market. And it's 2 doses between 2 and 6 months apart. And it's extremely effective. So more than 90% effective at preventing shingles and postherpetic neuralgia for at least 7 years. And just a comment that if you've had a prior shingles vaccine, that's not the one not the recombinant vaccine that's currently in use, you do still need to get the 2 doses of this most current vaccine for optimal protection. And that's my segment. Any questions?
I actually have 2 questions.
Mhm.
One is there any harm in getting a PCV20 if you're not sure what your previous, vaccination record is, or if your doctor has moved and you can't find it?
Mhm. Yeah, I would say it is unlikely to be harmful, very, very unlikely to be harmful if you get the conjugate vaccine. There is a way, I mean, the New York City registry and may be able to recover some, and even Epic now may be able to recover some of these vaccines that you received with a provider, even if it was years ago. You may be able to track down what vaccines you got. But I think, the bottom line is, it's very unlikely to be harmful, and we do vaccinate with the conjugate vaccine if people have an unknown vaccine history all the time.
Okay, great. And another question which I get occasionally is, what is walking pneumonia?
Walking pneumonia usually refers to mycoplasma pneumonia. That's usually the sort of phrase that we use with mycoplasma. That's a different type of pneumonia. Pneumococcal pneumonia tends to be a very serious pneumonia that you get it's not a walking pneumonia. You're pretty much flat on your back with that one.
Got it. Okay, I don't see any other questions in the chat, so I think we can go on. Thank you, Dr. Carmody.
Sure.
Okay, can you hear me?
Yes.
Wonderful. So again, thank you for the invitation. We are so happy to be here and share information. We really are passionate about improving the health of our patients and communities, as the mission statement for the Vaccine Center is, and what better way than sharing information about the currently available vaccines and some information on what's in the future. So I included brief information on the slides, but I'm happy. I get a lot of questions, as you might imagine, about the COVID-19 vaccine. So really wanted to leave room and time to tailor to whatever questions the people that are listening might have, so to address those. As you mentioned, and most people have heard, there is an updated COVID-19 vaccine. We were just talking just before we started the presentation with Jed. What is the terminology? Do we call it a booster? Do we call it something else? And the preferred terminology, the preferred wording is that it's an updated COVID-19 vaccine, because it really has been updated to reflect what's circulating, just like we've been doing with the flu shot for decades. So updated in the fall. So briefly, I do want to mention that the COVID-19 vaccines have prevented a staggering number of both hospitalizations and death, in addition to overall infections and illness. According to some estimates, this was until almost a year ago now, close to 20 million hospitalizations had been averted and 3 million deaths attributable to the COVID-19 vaccines. And I do want to stress that the COVID-19 vaccines are safe and work very, very well. A week ago yesterday, the FDA approved, and a week ago today, the CDC recommended the updated COVID-19 vaccine. And the recommendation is actually very straightforward and easy. Fortunately, unlike perhaps some of the recommendations for the pneumococcal vaccine that Dr. Carmody was sharing with us, that might be a little bit more complex. Everyone 6 months and older should get an updated COVID-19 vaccine. I would say everybody 5 or 6 years old and older needs one dose, while those that are younger might need more than one updated dose. But as long as it's been 2 months or more since your most recent vaccine, or if you've never had a vaccine, and regardless of whether you've been infected in the past or not, it is recommended that everyone gets an updated COVID-19 vaccine. The cases of COVID-19 certainly are on the rise. You can move on to the next slide, Olivia, thank you. This is clearly shown. This goes back, till August 2020, and you can see how these are just the admissions. So it's not even the cases, are people being hospitalized. And if you pay a little bit attention to the numbers, that first line, I'm not sure if you can see the arrow here, 20,000 per week. So we're already, as of 10 days ago, at 20,000 people being hospitalized per week for COVID-19, clearly going up after a period that we enjoyed a decrease in the amount of activity. So it is very timely to have an updated vaccine. Go on to the next slide, please, Olivia. And this is also reflected, as we can see here, year to year, the changes in COVID-19 associated deaths in people more than 20 years of age. And we can see it divided by age group. And a couple of things I like to point out from this slide. One is that clearly we know that those, just like Jed was saying at the beginning, those that are a little bit less young, as I like to call it, are at certainly a lot more risk for severe infection, hospitalization, death, and other complications from the virus. So we see much higher rates of mortality the older than people get. That most people are familiar with that, but the numbers are striking. On the other hand, I do want to point out that even in young people, look at these numbers. So for 2021, 23,000 people in between 20 and 44 years of age in the US died from COVID-19 associated causes. And last year, it was close to 6,000 young people. So these are very, very significant numbers. So even though the higher we go with age, the higher the risk, younger people are still at risk, and COVID-19 continues to be a very significant cause of illness and complications, including death in the US, even though we are a lot better. And just from the first half of this year, in those 65 and older, that continues to continue to be disproportionately affected by this nasty virus, already 25,000 deaths. And with the cases on the rise and waning immunity, we expect this number could continue to rise significantly as we have entered the fall season, and we have wonderful tools to limit the impact. Go on to the next slide, please. So many of you have heard about variants, and just briefly, without getting too much into the nitty-gritty, but I'm sorry, I don't know if somebody might need to mute, I would appreciate that. The viruses, the mutations are, as I call them, they're sloppy mistakes. Every time, what every virus wants to do is make more virus, copy and copy and copy itself to make more virus. And in order to do that, they need to copy the genetic material time and time again. And the RNA viruses, just like the flu virus and just like the coronaviruses, unlike, let's say, a DNA virus, which would be, for example, the shingles virus, RNA viruses don't do a lot of proofreading. So they're more sloppy. So they make more mistakes. Those mistakes are mutations. So many of those mistakes will be a dead end. They will lead to a virus with a change with a protein that doesn't work, will not infect, will not be able to assemble new viruses. But by chance, the more virus there is, the more mutations there are going to be. And by chance, some of those might have an edge, might have a competitive advantage to previously circulating viruses. And that edge could be either because it's more effective, right? It transmits from one person to the other more readily, or because it enables it to escape the protection afforded by the immunity that we've developed in response to the vaccines or previous infection more readily. So that's what, you know, why the viruses mutate, how they mutate, and why we have new variants. Next slide, please. So as I was mentioning, we do know by now very clearly, we've been studying this virus more thoroughly than any virus in the history by nature of, you know, it's had such a tremendous impact worldwide that a lot of resources have been devoted to studying this carefully. And we do know that the protection from previous vaccines or from previous infection decreases over time. And that can be attributed to two things. One is that just the level of protection decreases over time because it's been more time from when our immune system was reminded what the virus looked like. And the other part is that these newer variants, as we were just describing, are not neutralized, are not stopped as well by the immune system as it was taught by the original vaccines or the original strains of the virus that infected us. So by now, we know that our protection that we have has diminished. In the previous bivalent boosters were recommended about a year ago. So most people who have received all of the recommended and available vaccines have done that quite a while ago. So that has decreased. And these newer variants that are circulating have a number of mutations, a number of changes that they enable it to escape protection, escape neutralization. So the newer vaccines were recommended in the spring, targeting what was going around at that time. And there are more and more people we can read on the news media or hear on the news, depending how you get your information, concerns about the circulating variants nowadays might not be exactly what was going around in the spring when these new vaccines formulation was recommended. But the truth is that what's going around is all very, very similar to what was recommended in the spring, and quite a bit different from what was going around a year ago. So we do expect, and we have, you know, some initial studies to show that we're going to have good protection against what's going around now, you know, any of a number of variants with a booster or excuse me, an updated vaccine from the ones that just are becoming available, you know, between last week, this week, next week, depending on your pharmacy. And these are expected to be better at fighting the circulating variants. Of note, this is a monovalent updated vaccine, as opposed to the bivalent from a year ago. A year ago, it was bivalent, including the original vaccine, plus what was going around at around that time, or when they had to decide how they would make the composition of the vaccine. You know, studies that we at NYU Vaccine Center and other sites have done have provided support to us, knowing that we do not need the bivalent, meaning that we do not need the original variant to be part of the mix of the vaccines, because we know that the most updated vaccine protects not only better against what's going around now, but also it gives what we call back boosting. It increases the level of protection against the original variants. And that is important because we don't know where the next variant is going to come from. If we think of, you know, these different variants as the different branches of a tree, the next variant might be a daughter branch of the branch that we're on now, or could be a daughter branch from one much further down in the tree. So could be different. But if it's more similar to the previous ones, we do know that we have back boosting with an updated vaccine. And we know that, again, from studies that we at the NYU Vaccine Center and others have done. And that means also 100% of the composition of the vaccine is the updated one, while a year ago, it was 50% of one and 50% of the other. So we have more of the protein, the antigen that Dr. Carmody was telling us about, or the messenger RNA that's going to make the protein, with all of that with the updated vaccine. And we don't have the exact data of how much will it decrease the infections and illness and death from the one that's just being released now, because it's only now being released. But the most updated vaccine, that was a bivalent from a year ago, there's data that says that even for people that had received all of the previously recommended vaccines, getting that additional booster decreased the risk of death by about 60%. So that's not comparing to somebody that never received a vaccine, that we would expect even much more relative protection. But again, somebody that was up to date, except for that new the bivalent a year ago, if they got the bivalent, the risk would decrease another 60% of death. Next slide, please. And so again, are the vaccines safe? Is it not too risky to get these many vaccines? Certainly, we get these questions. The vaccines are extremely safe. As we were mentioning, not only have we studied this virus in a lot more detail than other viruses or bacteria in the past, but we have studied these vaccines more closely than any other vaccine in the past, because of the resources that have been poured, because this virus has had such a huge impact in our communities. And the vaccines are very safe in terms of serious side effects. Risk of a severe allergic reaction which has been reported, like with any medication, with any vaccine. With this, it has been close to 1 in 200,000 doses, a severe life-threatening reaction or anaphylaxis, which again can be typically treated. Any doctor's office or any place that gives pharmacy that gives a vaccine should be prepared to treat a severe reaction. Another very rare but potentially scary side effect that has been talked about with the mRNA vaccines, which are the two that have been recommended as updated, the Pfizer and the Moderna, is the risk of myocarditis or pericarditis, inflammation around the heart, that has been seen mostly in young boys and young men in the ages in between 12 and 40. And this has been reported after the first and second dose mostly. And it is still a very rare side effect, and it was seen mostly after the first couple of doses, much more than subsequent doses, as best as we can tell. On this slide that the CDC shared on their presentation when they were reviewing the risks and benefits and the information we had available before coming up with the recommendations, with the bivalent booster on some of these higher risk group, they didn't have cases of myocarditis in about 110,000 individuals that received the vaccine. And importantly is to think, okay, how many infections, hospitalizations, and deaths are we preventing? And even in young people, it's a lot more illness that we're preventing with the vaccine than the potential very, very rare risk. But by the way, the virus also can cause inflammation around the heart. Next slide. So before I move on into some of the upcoming research with regards to COVID-19 vaccines, a couple of things that I didn't include on the slides, but I then make notes to remind me to tell you about. One is long COVID. There is a growing body of evidence that the vaccines do decrease the risk of developing lasting symptoms after a COVID-19 infection. And then the other thing that I wanted to mention with the target audience for this talk, which has to do with the therapeutics. Of course, the updated recommendation was about the vaccine, but we do have important therapies for COVID-19 for those at highest risk for progressions, whether it is older individuals or whether it's people with underlying medical conditions. If you or a loved one do develop COVID-19, contact your physician very, very promptly, because the sooner the better as it comes to therapeutics. We have antivirals both by mouth and IV. Most people that are not in the hospital are typically going to be candidates for an oral antiviral that decreases in about 90% the risk of progression to severe disease once you do get COVID-19. So that is a very important a weapon in our toolbox. And those in the hospital, there's an IV option as well. Obviously, talk to your doctor. Some of the oral medications can interact with some other medications, so things to be aware, but most of the times that can be managed. And that's it. We can move on to the next slide, Olivia. So in terms of what's up and coming, so Congress has allocated funds for advancing the field of COVID-19 vaccines. And one of the agencies that's going to be tasked with this is the National Institute of Allergy and Infectious Diseases. And they have labeled this Project NextGen jointly with BARDA is the other agency that will be spearheading this initiative. And it is a coordinated effort where both the federal government will be working with the private sector to advance the pipeline of new and innovative vaccines and therapeutics. It aims to accelerate the development of the next generation of COVID-19 vaccines. Sometimes with the promise but uncertainty of how they're going to pan out these new vaccines, it might be too costly, too risky for private enterprise, small startups to commit to advancing this. But with the support of the government, with these funds allocated by Congress, they'll be able to advance promising agents into clinical trials. And this is expected to not just hopefully give us much better COVID-19 vaccines, but really advance the science in the field of immunology. What we're thinking is that these research studies are going to help us not just for COVID, but the next pandemic. We have used, many people sometimes wonder, how has the vaccine against COVID-19 been developed so fast, they say, and they're suspicious because of that. But the truth is that we have stood up on the shoulders of those that have done the research for the last 20 and more years. And some of those were done with other viruses like the Middle Eastern coronavirus or with RSV, which you'll hear about in a second. Some of those discoveries were used to develop the COVID-19 vaccine. Similarly, we think that some of the advancements in the science of immunology that we get to with these studies are hopefully going to be helpful for the next pandemic. So these next generation vaccines are expected to have either or enhanced breadth of protection to variants. So we don't need to necessarily be chasing every variant, but hopefully will be more of a pan-coronavirus vaccine, and or improve durability, so not to wane after a few months to a year, but really be more sustained, hopefully. And or we're really hoping to achieve enhanced ability to block infection or transmission. We know the vaccines that are available now are excellent at preventing death and severe infection. They're not quite as good at preventing infections or transmission. So we're looking into newer vaccines, including mucosal, nasal vaccines that we're thinking might prevent that. So we at NYU Langone Vaccine Center will be partnering with NIH, National Institutes of Allergy and Infectious Diseases, in carrying out these next generation vaccines in our clinical trials at the Vaccine Center. I think that's it, Olivia, and I'm happy to address questions.
Okay, I do see one question here, and I have a question. If you have recently been infected with COVID, how long do you recommend a person wait until they receive the new updated COVID vaccine?
Thank you for a question, a frequent question. I'm not sure that the CDC on their recommendation very specifically addressed that. They did say 2 months from the previous infection, the previous vaccine. I think 2 months from the recent, 2 to 3 months from the most recent infection makes sense, because we do know that your immune system is going to be boosted after a recent infection, and obviously we would expect that to be with a circulating variant. So 2 to 3 months is reasonable, is my recommendation.
And you had mentioned waiting a certain period of time after your previous booster to get the new updated. Did you say 6 months?
No, just 2 months is what CDC says, correct.
Okay, good. And one other question just about Paxlovid and the other antivirals is what is kind of balancing the risk for rebound COVID, which can happen with Paxlovid, versus the danger of long COVID, myocarditis, other, serious, pneumonia related to COVID. What would you say to somebody who's questioning taking Paxlovid?
Thank you. Excellent question. We hear that a lot. It's, in my mind, it's an absolute no-brainer, and the concern about rebound is not a reason not to get Paxlovid. And I'll tell you why. Number one is that rebound can be seen with or without antivirals. So we know that rebound can occur even if you don't take anything. And number two is that rebounds have not been serious for the most part, have not led to hospitalization or severe disease. It's just, oh, you test positive on the test more than anything else, rather than really seeing severe disease. Well, we said, I mean, we're recommending that for those that are at higher risk, and it decreases in 90% the risk of hospitalization. COVID-19 can still be nasty, especially those with underlying conditions, older or weakened immune systems. So definitely recommend you get Paxlovid, regardless of that possibility of seeing rebound, which is not typically serious.
I wanted to ask about side effects because I had a minor one, but it gives me pause. And then actually 2 doctors have said things to me that give me even more pause. So I've had all the vaccines that they've told us to have. The first one I was wiped out like other people were, nothing, whatever. The first bivalent last fall, that area where I got it, it still itches. And I had to, I was putting on steroid cream and whatever. I finally went to the dermatologist and he gave me a non-steroid. And now there's an over-the-counter thing that I'm using. I'm kind of managing it. It's less bad, but it was not great. And because of so much steroid, the area is a different color kind of on my skin. My dermatologist said it will go away eventually, but it hasn't. I mean, it's been almost a year now, but it has diminished. So when it was time to get the second booster, I dawdled, and I finally decided the first was one brand, the second one I got on the other arm, the different brand, and I didn't have a reaction. So I'm happy about that, but a couple of questions. I will get the second, I will stay with the other company, just in case. Now, even though I had mixed the earlier ones, I used either, I've used both, and I'll get it on this, on the arm that doesn't itch. Should I get the RSV on that arm and the flu on that arm, stay away from the itchy arm? That's one question. I have more, but.
Okay, I'll start with that. First, thank you for sharing your story. 2, I'm sorry that you had a side effect that was certainly unpleasant for all this time. 3, I would say just a general comment. We cannot give very specific advice to you, and the general recommendation would be talk to your doctor. But in general, I would say in terms of the side, I don't know that there's good science to inform that one side would be better if you had a side effect. I probably, if I were in your shoes, would choose, the one that I'm not having any symptoms, so the one that you've done better with. But I don't think there's good science that informs us of that. We don't know why some people have some more, not usually serious, but sometimes bothersome and lasting side effects. It's rare. And as you're pondering the decisions of whether to do it or not, I would, definitely consider that COVID-19 is serious and what we're preventing is significant. So probably the risk benefit is still worthwhile even for somebody like you. Mhm.
And I don't like a lot of risk. I will do it, but I'll tell you, my dermatologist isn't getting more shots. He said he's seen so many reactions, he isn't going to do it. And then my foot doctor, who I don't know the dermatologist well, so I don't know his whatever. My foot doctor, who's very science, he isn't getting it because he's had an autoimmune reaction that the arthritis doctor, who he had never needed before, said, yeah, it's quite possible that it came about from the vaccine. I mean, he was very healthy. So that, that's like, oh, is that itch, for me, the little itch, is that going to lead to something big if I get more shots,
Yeah. Great questions. Obviously, the concern for triggering an autoimmune process, which, by the way, has on a rare occasion been reported to happen after a vaccine, it certainly has been reported to happen secondary to infections. We know that autoimmune diseases are typically a combination of genetic susceptibility and some environmental triggers, and it is thought that infections can be some of those triggers, but a vaccine that activates your immune system is conceivable to do that as well. Some things to consider that as we're giving this vaccine to hundreds of millions of people around the world, we are going to have anecdotes of people that developed a disease or a problem after receiving a vaccine, whether that was caused by the vaccine or not. We would need to look at the specifics. It's sometimes very hard to prove on an individual basis in terms of at the bigger. There's robust surveillance mechanisms that by the CDC, FDA, and others to try to identify any safety signals or concerns. And we mentioned the myocarditis was certainly one that was picked up. Really increasing the causes of autoimmune problems, to the best of my knowledge, is not something that has been well established to be linked with the currently available vaccines. We know that the AstraZeneca, which was never licensed in the US, but was very, very widely used throughout the world, and I would say saved a lot of lives, as well as the Janssen or Johnson & Johnson, that was associated with a very low risk, but potentially very, very serious of, clotting episodes, which could be serious. So there's a lot of surveillance going on after vaccines. The two that we're mostly talking about, which are the Pfizer and the Moderna, have been given to hundreds of millions of people or more throughout the world and studied very carefully and really are considered to be quite safe. But that's a good question.
Doctor, when will the vaccines be available in pharmacies? Are they available now?
They should be they should be available between this week, depending on the pharmacy. We were briefly talking just before coming on. I had an appointment for today, which the pharmacy canceled, saying they were not ready. They told me that they were going to have it next week. So every pharmacy might be slightly different, but anywhere between last week to the next week, most places should have it over the next week or two at the most.
Very good. Well, thank you, Dr. Becker.
My pleasure.
Yeah.
Olivia, you can move on.
Amazing. I'm going to pass it over to Lalita.
Thank you so much. And I'm loving all the questions and the discussions. I'm learning a lot from the questions as well, because we three haven't actually sat together and answered all these questions with each other, even with Dr. Becker and Dr. Carmody. So I'm going to finish up talking about influenza vaccine or the flu vaccine and the new one, which is the RSV vaccine. So among us infectious disease doctors, we often joke that RSV, which is also called a cumbersome name called respiratory syncytial virus, is one of the most important viruses that no one really talks about or knows about. So it gets most prominent in childhood. So Dr. Becker probably knows a lot more about this virus than most of us. The other group it really causes problems with are those who are frail and those who have problems with immune system, so sort of extremes of age, like a lot of our infectious diseases. But this vaccine is brand new. So this is the first time it was approved in the 1960s. There were a few trials in young children, which did not go well. So the production and the distribution of the vaccine was entirely halted for many, many years. And the research in this vaccine, however, picked up over the last 10 years, where researchers from NIH figured out a way to fold the protein of the vaccine to create it. So it's taken quite a while for us to reach to the approval. So like some of the other vaccines, such as flu vaccine, this is a protein vaccine. So this is not a brand new platform like the mRNA vaccines. It can be considered somewhat a more traditional version of vaccines, where we take a small portion of the protein and use that as sort of an educational tool for our immune system. It is available right now as a single shot. So one vaccine is what is recommended. As for the virus itself, most of us are exposed in childhood, but we don't land up having lasting immunity to it, such as, for example, measles or chickenpox. Sometimes you get it in childhood, and the immune system really remembers that infection for a very, very long time. This particular virus, even though a lot of children get it in childhood, we really don't remember. Our immune system tends not to remember how to respond to it. So most of the infection in adults are what we call reinfections, and they may vary from year to year and how bad the season is. This particular virus, like a lot of our cold and cough viruses, I'm just going to call them respiratory viruses. They attack the upper nasal passages and then go down to the lungs to cause serious problems. They typically get transmitted by contact. So we really encourage hand washing a lot in this respiratory season, which typically starts in our city and state at some point in September and October and lasts through February and March. We also emphasize that the spread of the virus is often through coughing and inhaling the secretions of a sick person. So lots of hand washing and emphasis on not touching your face and the mucosal surfaces of your face with your hands and things like that. So as I mentioned before, big problem in infants, and recently one of the vaccines for RSV was also approved in women who are pregnant in an attempt to protect the infants. So most of the adults who are less than 50 years old, who are healthy without medical issues, have a pretty bad cold with this virus and recover without major pneumonia or problems breathing. However, if the virus progresses and goes down to the lungs, then it can cause a pretty bad pneumonia, and in some cases can land up people in the hospital. So in the older adults, especially those over the age of 65, we've estimated that it can cause from 60,000 to 160,000 hospitalizations per year, and also can cause from 6,000 to 10,000 deaths per year. So it is on a lower range compared to the other viruses, such as the COVID virus and the flu virus. But this disease is also not on people's radar for testing, so it may be an underestimate. What has happened over the last few years is the testing has really improved. Along with the COVID virus, now we have testing available for the respiratory syncytial virus, or the RSV. So we are probably hearing more about it, and we're going to start detecting it a lot more just because the tests improved for all of these viruses over the COVID pandemic. Next slide. So I wanted to put this slide in, which is pertaining to New York City especially, and I want to show you that the red line that looks so high up was our respiratory virus season from 2022 to 2023. And all of the other lines are the seasons before. So we have the other lines, other colored lines from 2018 all the way to 2022. And the red line was last year. So you can see that it was pretty different, and we don't really know why it was so different. Granted, these are positive results, and not necessarily all of them represent actual cases or serious illnesses, but I'll show you in the other graphs, there was a change, and it did correlate to increase in emergency room visits and hospitalizations. So last year respiratory season started early. It also started in October, peaked in November, which was several months earlier than the other seasons. We don't really know the reasons for that, but we think it may be because of just humanity wearing sort of less masks, and everyone having a little lower precautions, which we were doing in 2021. In this year's season, nobody really knows when it's going to start, but some early indicators show that in the southern part of the United States, there's already been an uptick in RSV infections. So we're thinking that this year too, we may have an earlier season start. And that's why we're having the session now in September, to encourage people to get vaccinated earlier in the season than wait till much later, such as December, to get vaccinated. Next slide. So who are the groups most at risk for severe RSV infection? It's very common. So I would say COVID, pneumonia, pneumonia bacteria, the flu, and the RSV, they all share these risk groups in common. So we have people with lung diseases such as COPD, asthma. We have people with heart diseases such as heart failure, and even artery disease. So people who have stents and high cholesterol levels, high blood pressure, people whose immune systems are compromised due to transplant or other medications such as chemotherapy, radiation, things like that. People who have blood related cancers, so leukemias, lymphomas, people who are frail, living in nursing homes and other long-term care facilities. And then other groups, so people who have nerve problems such as Parkinson's, Alzheimer's, those with diabetes. Diabetes is a really big one, and it doesn't necessarily affect older adults. It really is beyond age of 50, but it predisposes you to any number of infections, kidney, liver disorders, and these are sort of, I would say, common for a lot of the infections. Next slide. So these two graphs are showing two things. And again, I want to show how different situation can be for all ages versus those over the age of 65, and how vaccines are strongly recommended for the over 65 age group. So the graph on the left side are showing the rates of hospitalization. So these are actual hospitalization rates per 100,000 people. The red line is COVID, which is the highest. The blue line is flu, and the little green line is the RSV. So even though the RSV is lower than the others, it's still up there. The COVID is the highest risk of the three. And then when you see the right side graph, which is showing specific hospitalization rates for those over 65, you see that for COVID, it's almost 4 times the number compared to all ages. For flu, it's almost 3 times the number. So people who are older have a much higher risk of getting hospitalized with these infections. For RSV, it's not as dramatic as the other two, but considering how few infections we detect, that curve is likely to be significant as well. So it's very important to plan your vaccinations, because compared to the other ages, your immune system may not protect you as well as someone who is younger, because our immune system goes through what we call immunosenescence, which is aging of the immune system, and it doesn't work as well as you turn older. Next slide. So to just finish up, I'm going to talk briefly about influenza. Influenza is one vaccine that hasn't undergone a huge change, so it's similar to the other years. but it remains a pretty big cause of death and hospitalization in adults who are older, those with risk factors, as I showed in the previous slide. So what is recommended for those 65 years and older is a high dose influenza vaccine. It is already available. I've heard of several of my patients getting it. I would suggest probably getting vaccinated over September and early October so that you give your immune system a chance to generate a good response when it actually faces the virus. And the current vaccine that's available has got 4 strains of the influenza virus, and we have cell-based vaccines as well as egg-based vaccines, so people can choose based on their allergies. Some people have serious allergic reaction in the past due to egg-based vaccines, have other option this year. And the COVID and flu vaccines from the prior season, we do have some research studies showing they're safe to be taken together. The next question is going to be, should we take the flu and the RSV together? We do not have a lot of information suggesting it's safe. What data is available, very small numbers of participants in those studies, and I would say probably to be on the safe side, wait 2 weeks between RSV and influenza vaccine. But the COVID and flu vaccines from the past seasons and other research studies, they've been shown that they can be taken together. Now, can you take all 3 together? Probably wouldn't suggest taking all 3 together or taking a massive number of vaccinations in the same visit, even though you may not want to go back to see your doctor. That works okay when the babies are young and their immune systems are very, very, what we call naive, meaning they're not exposed to a lot of things. So we give babies sort of a number of vaccines together. Probably not a great idea in adults because you can have much more serious side effects and you can't tell which vaccine produced it. So take a couple together if you really want to, but more than 2, probably hold off for a couple of weeks and then plan on taking them. Next slide. Yeah, I think I'm done and happy to answer questions.
Thank you so much, Doctor. I have just a comment, and you mentioned it, but I know for this particular audience that if you are caring for somebody who's in a nursing home or residential care, that it's really important, then that's part of their responsibility to provide really good infection control, to make sure that you ask the director of nursing or the medical director, when are they offering these vaccines? They should be offering COVID-19, the updated vaccine, the RSV, and the flu vaccine. So just, to advocate for your relative. And it's important for you, if you're visiting, that you get them as well, so that you protect the immunity of that community. So I just want to make that point. And we do have a question here. Is the RSV vaccine available yet?
Yes, I did hear it's available. It may so apparently, I'm not sure of this. I don't know if the amount of vaccine available, doses available are slower, but they're available in pharmacies. Your doctor may need to put in an order for if you're between the ages of 60 and 65 versus your insurance. That is the one additional step I've heard some doctors mention, that the doctor needs to place an order, but it is not across board. Some patients have been able to just go to the pharmacy and get it. So it may be based on insurance. I'm not sure, but it is available.
And I think it's important to remind people that Medicare does cover all of these vaccines. So I don't think everybody who's over 65 or otherwise on Medicare, that you should not have any out-of-pocket expense for that. I did have a question, perhaps for Dr. Carmody or for any of you, just because I have a relative who's in a nursing home, and I was speaking to another family there, and we were talking about getting the COVID-19 vaccine. And I said, look, I've already, booked my appointment. And this daughter was saying, nope, I've already had enough vaccines, so I'm not going to get any more. Enough is enough. And I said, look, talk to your doctor about it. I showed surprisingly good patience with her. But I wonder, any thoughts about how to respond to people who are hesitant or concerned about, or have, kind of unsubstantiated ideas about it?
I think it's, yeah, I mean, I think the most important thing that I've learned is that everybody's an individual and everybody has maybe a different reason and a different framework from which they are hesitant. And I think the most effective way in general is to validate people's concerns, or basically listen to their concerns, validate them in the sense that you're saying, I see you are very concerned about the harmful effects on the heart. You're something, you're very concerned about your heart, and that's a very important, and I know that you do a lot of other things to protect your heart. And then you can say something like, I don't know, this is off the top of my head, that COVID-19 can also really affect the heart. And I think that in general, the idea is listen, validate people's concerns, and then see if you can use those concerns to approach a gentle correction of misperception. And I also think it's important to pick your battles. So I would be much more concerned about somebody who is 80, who is, not accepting of a COVID vaccine. Perhaps they have never had a COVID vaccine and they've never had COVID. That's a very unlikely situation. But, that'd be somebody who I'd be much more concerned about than somebody who was 20 and saying, I don't want another COVID vaccine. I had 3 and I've had COVID twice. Yeah. So, I think some things you just got to let rest. And then those things that you have to focus on those people who you really think are most at risk.
Thank you. I don't see any other questions from the group.
I also wanted to just add one thing about the doctor who said they got autoimmune disease. Sometimes physicians can also have, when it's someone's health, people become very, I've noticed it as well. People become focused on finding a culprit, and doctors are also human beings. And oftentimes they also have the medical knowledge, which can be dangerous sometimes, it can be helpful. So I think when you have someone saying, I'm not going to do this, that's fine. That might be an appropriate decision for them, but always think about yourself and your own health issues and your own risk when accepting that advice as something you should do or not. So it may be pertinent to their particular health status, but it may not be relevant to you at all. So just to show that these discussions sometimes have to be, thought about for your own individual risk compared to someone else's.
For the sake of time, I'm going to move us along. I know, Dr. Parameswaran, we would love to hear some of the updates about the clinical trials currently going on at the Vaccine Center, as well as trials that we have upcoming. So we have one last Q&A that we can do at the end, but for sake of time, I'm going to move us forward to vaccine clinical trials, where we are and where we are going.
Great.
So at the Vaccine Center, we currently actually our ongoing studies are these. So RSV, as I mentioned, is a big problem in people who have poor immune systems, especially those who have cancer and transplant, lung transplant, heart transplants, or bone marrow transplants. So typically in most of the Vaccine Center clinical trials or vaccine clinical trials conducted nationally, the groups that are having poor immune responses are excluded. most of the time what happens is when the rest of the population takes the vaccine, for example, the COVID vaccine, the virus actually continues to cause serious issues in those with poor immune system. So for the RSV vaccine, we just finished actually enrolling people who are high risk for RSV. And this is a slight sort of paradigm change that is happening, which is positive overall for research in general, that we are trying to do trials in people who have risk factors for the disease. So that was our RSV study that we completed enrollment recently with the currently approved RSV vaccine, and we gave 2 doses of it to those with chronic health conditions or poor immune system. The next study that we were hoping to enroll is the mRNA influenza vaccine using the same platform as the Pfizer vaccine. And then we have what we call observational studies, where we basically don't provide a vaccine, but we take blood from people who have received either a flu vaccine or an Mpox vaccine and hepatitis B vaccine, and study their immune responses. So as you can see that the vaccine center sort of has these trials along the large spectrum. So we conduct clinical trials. We are part of a lot of the COVID studies, the influenza studies, the RSV studies, but we also have observational studies where we're looking at immune responses. So a lot of these educational efforts are coming from understanding those trials that are published and kind of clarifying it and providing it as an educational session so that the community is well informed about what actually goes on behind the scenes, which leads to the approval of these vaccines. So we worked really hard, and our big goal is to improve the representation of all types of population in our clinical trials, which includes racial and ethnic minorities, whom I haven't shown the slides, but all of the infectious diseases are very, very heavily affecting those with racial and ethnic minorities in terms of hospitalization and death rates because of a variety of factors. And so we worked very hard to enroll a very diverse set of participants. And then the other group that typically gets excluded and is often commented upon when FDA reviews the data are the older adults. So a lot of these diseases affect older adults, as we've shown in all our previous slides, but the representation of older adults in our vaccine trials sometimes is not necessarily where it needs to be as compared to the other age groups. So we work very hard. We have many ways of recruiting, and we've been able to actually have an excellent older adult representation in all of the trials that we've conducted in NYU. Next slide. So what's upcoming for our vaccine center? So we are, Dr. Backer is leading our COVID next generation vaccine studies, where we hope to develop vaccines that will have a longer duration of response, immune response. We hope to develop vaccines that will not be affected by simple mutations in the virus, and also hope to develop vaccines which work for all age groups equally well. That is our hope. So Dr. Backer will tell us, hopefully next year, what he achieved by doing some of these cutting edge studies. Some of the other studies that are upcoming include shingles vaccine, Group B streptococcus vaccine, which is a bacterial vaccine, and an mRNA Mpox vaccines. These will start in the next 1 to 2 months. And we hope to, again, have a good set of participants as most of our trials. Next slide.
So I will take over for you for this
Yes.
last slide. I would be remiss to not circle back to our recruitment and community engagement efforts whenever we get the chance to interact with communities like such as yourselves. So if you are interested, if anything that we have been talking about interests you and you would like to stay in touch with the Vaccine Center, there are multiple ways to do that, and we would love to continue our relationship with you or friends and family who may be interested as well. A couple ways to do that I've outlined here. Number one, if you are interested in participating or receiving updates in the most regular way, the best way to do that would be to join our participant registry, So it's very basic, just some information about yourself. It gives us some contact info, and we reach out whenever you are eligible for a clinical trial or an observational study that we may be starting. So this gives you the opportunity to receive those tailored recommendations from our team to say, you know, you meet the age and stage for this vaccine or this clinical trial we are doing. Does that sound like something you're interested in? You can decide yes or no, and then continue to get those updates as they go along. If you're interested, we'd help you enroll. And if not, that's totally fine. That's also how we send updates about our newsletters. We have a website below, and there are links. These slides will be available afterwards, and these are active links. So you're able to direct yourself to our registry. It's available in English and in Spanish, as well as our website, where we try very hard to post our updated publications, our new and ongoing studies. And as a participant, it's really important that we communicate what happened with these studies. What did we learn? What did we accomplish? And the role that our participants had. At the end of the day, we cannot do the work that we do, and our experts do not have the knowledge that they have without our community volunteer participants. So it's very meaningful to us, and we do try very hard to have events and post those updates back to you, so you know what role you played in these scientific developments. We also have a Twitter and soon to be an Instagram. And then lastly, if you have any questions or would like to get in touch with any of our experts specifically, that's our just general vaccine center email at the bottom, and we are able to direct your message accordingly.
Great. Olivia, I have one last question from a participant. First of all, I want to thank you and the team, because I think it's just extraordinary what we've done here. And I would love to do this again, next September. I think it's a really important way. And I want to also just remind our participants that we'll put this on our website. We'll send out the slides to you, as well as a brief, just kind of a questionnaire about what you thought of tonight's meeting. But our last question is for a woman whose husband is in a nursing home. He has Lewy body dementia. He's 78 years old. Should he get the updated vaccine? And if he does get COVID, should he get Paxlovid? And I'll leave that up to probably Dr. Becker or whoever wants to respond.
I'm happy to take it, though, and any of my colleagues could take it as well. In general, I'm going to do the same disclaimer that I said before. I cannot give specific recommendation for an individual. That's not my patient, and I don't have the full history. So I would recommend talking to your husband's doctor specifically. I'm going to say generic terms, saying if you would like to decrease the risk of him getting COVID-19, I think an updated COVID-19 vaccine is in line with the recommendations by CDC, and that is the most effective way to decreasing the risk of developing COVID. And as I was mentioning also during the presentation, for those that, based on age, I would say he would be at higher, should he develop COVID-19, should he get infected, will be at increased risk for having complications or a more severe illness, especially if not updated with the vaccines. And for most older people, a therapeutic like Paxlovid will be recommended. As we mentioned, there is the potential for some interactions between Paxlovid and some other medications, so would need to talk to your husband's doctor specifically if and when, should that occur. But for most people in that age group, if they get COVID-19, that's likely to be recommended.
Great.
The last thing I will mention, and it's not finished now, I realize in the haste of putting this presentation together, I've left poor Shingles. Doesn't have their references at the bottom, but there is an educational resource and reference page at the end if you would like to look at some of the websites that our experts trust for up-to-date information and trends. So that page is at the end and summarizes a lot of those pages that Dr. Parameshwaran, Dr. Backer, and Dr. Carmody pull from to inform these presentations. So in a sea of misinformation, these are very trusted and well-respected resources, should you want to reference them.
Very good. Well, thank you all. I am just a lot of really good information, clearly presented, understandable for those of us who did not go to medical school. And I really appreciate it. So thank you, Olivia, and thank you, wonderful team at NYU Langone Vaccine Center. And so thank you
Thank
very
you,
much.
Jed, for inviting us. Thank you for hosting us, and we're happy to share information. Thank you for the interest.
Pleasure. Okay.
Thank you so much, Jed. As always, a delight. And I hope to chat with you again soon.
Okay.
I'm
very
going to
good.
stop
Thank
the
you.
recording. Thank
Yes.
you, everyone.
Yep.